Welcome to Medical Human Gross Anatomy, Quillen College of Medicine, East Tennessee State University. In today's presentation, we'll cover the posterior abdominal viscera, kidneys, ureter, and aorta, as well as a number of clinical correlates relating to these organs. So the kidneys are retroperitoneal organs. Their main function, which you'll learn much more about in physiology, is to filter blood and to produce urine, and in doing this they absorb, reabsorb nutrients and water. They help to regulate salt and water balance, and also, because of that, have an important role in regulating blood pressure. Now, the kidneys are retroperitoneal organs, which I've already said. The right kidney sits slightly lower than the left kidney, and that's due to the large liver on the right side. The left kidney sits slightly higher and is related with the 11th and 12th ribs posteriorly. The renal hilum or hilus is the mid portion, the center of the kidney, where the ureter and the renal arteries and renal veins are entering and leaving the kidney. Now, the kidney has a capsule, which you'll be able to see grossly when you dissect the kidney. It'll be a connective tissue overlying the kidney, which you can actually peel away from the renal cortex. There's also a cortex and medulla, which we'll look at anatomically, and you'll be able to see in lab when you dissect the kidney. You'll also learn much more about the cortex and medulla in physiology and in histology as you move forward in your other courses. So keep in mind that there is a capsule, a renal capsule surrounding the kidney. Now, there's also some renal fascia, which you can see depicted in this image here, and it's labeled anterior renal fascia and posterior renal fascia, but there's this fascia which is encompassing both kidneys, and notice that it also encompasses the aorta and IVC in this image, and you'll see why that's important in just a minute. But this renal fascia separates the perirenal space and the pararenal space. So there's the perirenal with the I, perirenal space, and that is the space just internal to this fascia, if you will, that's most intimate with the kidney. And then the space external to this renal fascia is the pararenal space. Now, this consists of mostly adipose tissue, but clinically you can see how it walls off the aorta, the IVC, and the kidneys. And so this is important clinically, particularly in imaging. If there's a bleed from the aneurysm, or if there's a bleed from the kidney or from the renal vessels, or if there's damage to the ureter and there's leakage of urine from the ureter, all of these structures are encased by this renal fascia, and so they will all be maintained in this space here, in the perirenal space. So that's important to realize, and you'll see imaging if you see a bleed from the kidney or a bleed from the aorta, how it can often encompass the kidney. Frequently a bleed from the aorta, you'll see the blood more along the lines of the kidney, but the actual result of the blood is from the aorta and not the kidney. So this renal fascia separates the perirenal from the pararenal space, mostly fat, but clinically can be important to help identify if something's going on and where it's going on due to what it is encompassing. So be sure you understand the renal fascia and the perirenal and the pararenal space. Now, in lab, I encourage you to bisect the kidney, cut it in half, open it up like a book so that you can see the structures inside. And in well-preserved kidneys, you'll be able to appreciate these. Again, there's a renal cortex, which is the outer layer. You should be able to see a definition between the renal cortex and the renal medulla. In normal kidneys, in non-diseased kidneys, it's about 7 millimeters. Now, that can become thinned out in diseased kidneys, particularly kidneys suffering from hypertensive disease or other arteriosclerotic diseases. So there's the cortex. The cortex contains these renal columns, which are diving down and separating the renal pyramids in the renal medulla. And then deep to the cortex is the renal medulla, which consists of 8 to 12 pyramids, and you can see these depicted here. They look just like pyramids. The tip of the pyramid is what's called the renal papilla, And so all of that is producing urine. The urine dumps from the renal papilla into the minor calyx. And so up abutting the renal papilla is what's known as the minor calyx, and that's where the collecting system starts, and you can identify that in lab. And then when two minor calyces join, come together, they then form the major calyx, and then the major calyx will drain out to form the renal pelvis and then the ureter. You will be able to identify all of those structures when you bisect the kidney in the lab. So be sure you identify the renal pyramids, renal papilla, minor and major calyces, as well as the cortex in the renal columns. Now the blood supply to the kidney is from the renal artery and renal vein, and again those enter in the region of the ureter at the renal hilus or the renal hilum. Important for you to know, but you won't be able to appreciate in lab grossly, is that the renal artery gives off some interlobar arteries, interlobular arteries, as well as arcuate arteries, and you'll hear more about these in pathology. But the renal arteries divide into segmental arteries to give blood to the different segments of the kidney, and then the segmental arteries divide into lobar or lobular arteries to provide blood supply to the different lobules of the kidneys. And then the arcuate arteries are what you see here in this picture, and those are the blood supply at that corticomedullary junction. So right where the cortex and the medulla meet, and that corticomedullary junction is receiving its blood supply from the arcuate arteries. Now these are important clinically because these are end arteries. They don't anastomose. They end right there. In arteriosclerosis, arteriosclerotic disease, atherosclerotic disease, hypertensive disease, since these are end arteries, they are very susceptible to hypertensive and atherosclerotic disease. So you will see microscopically, and when you get into histology and pathology, these arcuate arteries are affected by that. You'll be able to see evidence of that microscopically. You won't be able to see that in the lab. What happens in the lab when those become diseased, the cortex thins, and so that cortex becomes thinner than the 7 millimeter, the normal 7 millimeters that I told you about earlier. Now here's some clinical correlates we'll get to and we'll go over real quick. There's an entity known as pelvic kidney. You might have heard about that in embryology previously, and the kidney just does not ascend in the development. And so the kidney is stuck down in the pelvis. There's also a horseshoe kidney, which you heard about in embryology, and during fetal development the kidneys fuse, and then when they ascend they get caught, and they get caught by the ventral splanchnic. That's the lowest ventral splanchnic, which is the inferior mesenteric artery. So the kidneys sit lower because when they ascend they have the horseshoe, they're connected, which gets caught and wedged in between the inferior mesenteric artery, if you will. And so you end up with what looks like a horseshoe and is named horseshoe kidney. Now in the CT image, on the right hand side of the screen, you can see the red arrow pointing to a small vascular structure and a green arrow pointing to a larger vascular structure. The green arrow is pointing to the aorta, and the red arrow is pointing to the inferior mesenteric artery. And then in between those two is this horseshoe kidney, which you can see. And so you can see how that horseshoe kidney is sitting at the level of the inferior mesenteric artery. There's also an entity known as polycystic kidney disease, which you'll learn a lot more about in pathology. There's autosomal recessive, autosomal dominant polycystic kidney disease, but the kidney becomes enlarged and becomes encased or involved with multiple cysts. So you'll see this later on. You can also have just regular cysts of the kidneys that just happen. You also, if your patient underwent dialysis, they're more susceptible to producing multiple cysts of the kidneys. So sometimes there's no big deal. Sometimes the cysts can bleed. Sometimes in polycystic kidney disease, the renal parenchyma, the renal tissue, is less, and so renal function can be compromised. There's also renal tumors, which you will see later on in future courses, but I just wanted to make you aware that there are some renal tumors, and you may see some in lab today. And if you remember going forward into pathology, there's some color characteristics of different tumors, which we don't need to get into, but which can differentiate certain tumors. In the CT image, just so you know, you see the asterisk or the star showing a large mass, exophytic mass from the kidney, and the black is fat. So just one tumor you'll learn about when you see fat in a tumor in the kidney. It's an angiomyolipoma, which is a benign tumor, but sometimes can grow, and because there's an angio or a vascular component, can bleed. So you'll see that later on. Now we'll move on from the kidney to the ureter. Again, the ureter is retroperitoneal. It descends on the anterior surface of the psoas muscle. The gonadal vessels, or the testicular artery and vein, or the ovarian artery and vein, crosses the ureter anteriorly. And on its course, as the ureter continues down, it crosses the bifurcation of the common iliacs. There's two regions, which you see here in the box, called UPJ and UVJ, which is important for you to know about clinically and anatomically. The UPJ is the ureteropelvic junction, and that's where the ureter is originating at the pelvis of the kidney. And then there's the UVJ, which is the ureterovesicular junction, and that's where the ureter is inserting into the bladder. So these are important clinically. There are bends here. Oftentimes, kidney stones or renal stones, it's a frequent place for them to get lodged, and a common place to see on imaging at the stones at the UPJ or at the UVJ. And here we just see an image with the kidney labeled and the ureter labeled, and you can see the ureter descending down on the psoas muscle and crossing down and then inserting into the bladder. This image is to show you the blood supply to the ureter is multiple. It comes from the aorta, the renal arteries, the gonadal, so the testicular, the ovarian arteries, as well as the iliac and vesicular arteries. So there is no one supply to the ureter. It's multiple supplies, blood supply to the ureter. You can also see in the image on the right side of the screen, coming down the ovarian or the testicular artery, whichever the gonadal artery is, crossing anteriorly, and then you can see how the ureter continues to descend down and crosses where the iliac artery bifurcates. Now, some clinical correlates with the ureter. There's an entity called hydronephrosis or hydroureter. So that's hydronephrosis is in the kidney at the renal pelvis, and then hydroureter is in the ureter. So these become enlarged, and you can see in this image, the two radiographic images, there's contrast dye that has been injected in the patient, gets filtered, goes through the kidney, and then gets excreted through the urine, and the contrast enhancement allows the imaging of it to see it, and you can see it filling up the urinary bladder. Well, in that you can also see the collecting system with the renal pelvis and how dilated it is, particularly if you look at the radiographic image on the right side of the screen. The left collecting system, or it's the right collecting system but on the left side of the screen, is markedly dilated, and you can barely see the contrast in the left renal collecting system, and that's a more normal collecting system. But the right-sided collecting system is enlarged, that's hydronephrosis, and the ureter is enlarged and dilated, going all the way down to the urinary bladder, and that's what's known as hydroureter. This can be caused by many things. There can be obstruction, there can be backflow of urine from the urinary bladder. So just keep in mind that if you see dilated collecting system, it's hydronephrosis. Dilated ureter is hydroureter. And again, renal stones, kidney stones, you'll see these a lot frequently. Again, the two most common places due to the bends are the UPJ or the ureteropelvic junction, or the UVJ and ureterovesical junction. And there's an image here to show you the UPJ and UVJ, as well as a stone which can just get lodged anywhere in the length of the ureter, or in the course of the ureter. The upper right image just shows a KUB or abdominal x-ray, and the red arrow is pointing to a stone in that upper left abdomen region. The two lower images are CT scans, and on the left side of the screen in that CT scan you can see the arrows pointing out renal stones. The one on the right side of that image is probably just an intraparenchymal stone in the kidney. The one on the left side is probably at the ureteropelvic junction, about to come out of the kidney. And then in the CT image on the lower right side of the screen, the black arrow is indicating a kidney stone right there at the urinary bladder. So that's at the UVJ. So that stone's about to be passed into the UVJ, or into the urinary bladder through the ureterovesical junction. One of the causes of hydronephrosis or hydroureter, I told you, was reflux from the urinary bladder back up into the ureter and the kidney, and this is called vesicoureteral reflux. It'll be a common workup in children who have multiple urinary tract infections, particularly in males. There are different causes to this, but I just wanted you to know that if there is reflux from the bladder back into the ureter, it's called vesicoureteral reflux. The way they look at this is they actually insert a catheter, insert dye, or inject dye into the catheter, into the urinary bladder, and so the urinary bladder fills up with this contrast dye. And then under imaging, you can take some pictures throughout time and see that in a normal functioning urinary bladder with normal insertions of the ureter on the urinary bladder, the contrast of the urine should not have retrograde flow, should not flow into the ureter. And so if you see that contrast moving up into the ureter, then there is vesicoureteral reflux. And you can see in the radiographic image that there's reflux in the left ureter all the way up into the left renal pelvis or the collecting system. And then the grades, this is just graded from severity. So there's grade 1 all the way to grade 5 being the most severe. Moving on to adrenal glands. Again, the adrenal glands are retroperitoneal. They sit on the superior medial aspect of the kidney, so the upper and medial aspect of the kidney. So that makes them retroperitoneal. The adrenal glands also have a cortex and a medulla, which we'll see again in a few minutes real briefly. The adrenal gland on the right is more of a pyramid shaped. The adrenal gland on the left is more semilunar or crescent shaped, and you see that here. Now, these can be difficult to find in lab, but you can find them. Careful dissection, just look on the superior medial aspect of the kidney. They'll be more of a golden brown, tannish color, and sometimes a little orangish color to the organ, and you'll be able to see that. There are superior, middle, and inferior adrenal arteries or suprarenal arteries that are supplying the blood supply to the adrenal glands. And these originate from different areas. You will be able to see some of these in lab, identifying all of them on one cadaver. Sometimes it's tough because they're small, they get destroyed, but you should be able to see all of them. The superior adrenal artery usually arises from the inferior phrenic artery on that side. The middle adrenal artery usually arises straight from the aorta, and then the inferior adrenal artery usually arises from the renal artery on that side. Now, for venous drainage of the adrenal glands, the adrenal vein empties into the inferior vena cava on the right and into the left renal vein on the left. So there's usually one renal vein as opposed to the 3 renal arteries. And keep in mind that it has 2 different places where it drains. On the right side, drains straight into the inferior vena cava. On the left side, drains into the renal vein, and then the renal vein into the inferior vena cava. So I told you there was a cortex and a medulla. You'll learn much more about this in some other courses, but the cortex can be divided into glomerulosa, fasciculata, and reticularis, and that's where our mineral corticoids, glucocorticoids and androgens are secreted. The medulla is where our epinephrine and norepinephrine is secreted under sympathetic direction. Okay, moving on to the aorta. The aorta passes through the aortic hiatus, and this is at the TV12 level, so keep that in mind. Descends anteriorly to the vertebral bodies and courses down, and the bifurcation of the aorta into the common iliacs is at the level of LV4. The aorta bifurcates at the level of LV4 into the common iliac arteries. You've already seen the ventral splanchnics and heard about them in a previous presentation, as well as in lab. And so the anterior vessels, or the vessels coming off the aorta anteriorly, which are supplying the midgut, foregut, or foregut, midgut, and hindgut, are the celiac trunk, superior mesenteric artery, and the inferior mesenteric artery. So you've already seen those and heard about those. The other branches of the aorta that we'll talk about are coming off laterally, with most of all but one of them have two pair. The one that doesn't have two pair we'll hear about at the very end of the aorta section here. But the first thing coming off just below the diaphragm is the inferior phrenic arteries, and these supply the diaphragm, and again, as you already heard, give rise to the superior adrenal arteries. And the aorta also gives off the middle adrenal arteries, which is just above the level of the renal arteries. Now, two very important arteries coming off, which are located at the LV2 level, are the renal arteries. So you'll be able to see those coming off laterally from the aorta and coursing into the renal hilum. The right renal artery is posterior to the superior vena cava, and the left renal artery courses posterior to the left renal vein. And also keep in mind, as you heard earlier, that the inferior adrenal arteries are originating from the renal arteries to supply the adrenal glands. The gonadal arteries, so the testicular and the ovarian arteries, depending on if your cadaver is a male or a female, course laterally on the psoas muscle and cross the ureter. So that's important to keep in mind. The testicular artery, and you'll see this later as we move on in the course, but it will accompany the vas deferens into the scrotum and supply the spermatic cord, the epididymis, and the testes. In the female, the ovarian artery enters the suspensory ligament of the ovary to supply the ovary. And then there are 4 to 5 pair of lumbar arteries, which you can see in this image here, and these are coming off posteriorly and laterally, and these are known as the lumbar arteries. And then the one unpaired artery that we haven't talked about is the middle sacral artery, which arises at the bifurcation of the aorta posteriorly, and it descends on the anterior aspect of the sacrum, and this gives vascular supply to the rectum and the anal canal. Now, some clinical correlates. Dilation of the aorta. You've heard about this in the chest and the thorax already, that you can have aortic aneurysms. They're more common in the abdominal aorta than they are in the thoracic aorta, and they usually occur below the level of the renal arteries. So they usually occur between the renal arteries and the bifurcation of the aorta. They can also go down and occur in the iliacs, usually most commonly due to hypertensive disease. So if you just get dilatation, saccular dilatation of the aorta, it's known as an aortic aneurysm. They will watch these up to a certain measurement. I believe the measurement now is 5 centimeters, and you'll just have surveillance up until 5 centimeters, and then after that cutoff is when the risk of rupture greatly increases, and so then some type of intervention will be done. Moving on to the inferior vena cava, this is formed by the union of the common iliac veins, and it's slightly lower than the aorta. The aorta bifurcation was at LV4. The IVC is formed at the level of LV5, and then ascends posteriorly just to the right of the aorta. And like we heard, the aorta pierces the diaphragm at the level of TV12. The IVC pierces the diaphragm at the level of TV8. It's important to keep in mind a little bit of difference on the venous side as opposed to the arterial side here with the gonadal vessels, the adrenal vessels, and the phrenic veins. So on the right side, the right testicular, right ovarian vein, the right adrenal vein, and the inferior phrenic vein drains directly into the IVC. On the left side, those corresponding the left testicular, left ovarian, left adrenal, and left inferior phrenic actually drains into the left renal vein. And we'll see that. The IVC receives both the right and the left renal veins, and the left renal vein courses anterior to the aorta, usually, and posterior to the superior mesenteric artery. And the IVC also receives the hepatic veins from the liver drainage. You can have an instance, which you may see in lab, where the left renal vein courses posterior to the aorta instead of anterior to the aorta, and that's usually of no clinical significance, but it's called a retroaortic left renal vein. So you may see that anomaly in lab. So the left renal vein, we already mentioned this briefly, but the left renal vein courses anterior to the aorta usually, and posterior to the SMA, and again, instead of the gonadal, adrenal, and inferior phrenic veins draining into the IVC, on the left side, the gonadal, adrenal, and inferior phrenic veins are draining into the left renal vein. Now, because of that, that's important clinically. You see how the SMA courses directly over the left renal vein, almost like a nutcracker. So you can imagine the aorta and the superior mesenteric artery forming what would be known as a nutcracker, or similar mechanism as a nutcracker. And there is an entity called nutcracker syndrome, and that is where that angle, for whatever reason, sometimes rapid weight loss can do it, but for whatever reason, that angle between the SMA and the aorta becomes too acute, and it can actually pinch off or compromise the left renal vein. And so you can imagine what can happen if the left renal vein is not able to flow the blood back to the IVC. It can back up. That will affect everything that's draining to that left renal vein, so it can affect the left inferior phrenic, the left adrenal, and the left testicular or ovarian. Most likely, presentation of those will more than likely be the testicular vein on the left before, because engorgement of blood back into the testicles may cause some pain. So patient may present with testicular pain or testicular issues, or in a female, ovarian issues down in the pelvis. And the actual problem isn't in that region. The actual problem may possibly be up here in the abdomen, with where the SMA is possibly clamping down on the left renal vein. That's known as nutcracker syndrome. So that's an important relation clinically, that left renal vein coursing anteriorly to the aorta, but posteriorly to the SMA. And here's a cross-section just showing you the anatomy that we just discussed of the IVC with the left and right renal veins coursing over. Moving on to lymphatics and lymph nodes, we have preaortic lymph nodes and paraortic lymph nodes. The preaortic lymph nodes are the ones on the anterior portion of the aorta, or sit anteriorly to the aorta, and these all correspond with the celiac, superior mesenteric and inferior mesenteric artery, and if whatever group they're in, they're just called the celiac nodes, the superior mesenteric nodes, or the inferior mesenteric nodes. These drain lymph from the GI tract, the spleen, the pancreas, the gallbladder, and the liver. So anything that was, it corresponds with the vessels. So if it's draining lymph from the foregut, that's the celiac trunk, the inferior mesenteric, or the superior mesenteric nodes are draining lymph from the midgut, and the inferior mesenteric nodes are draining lymph from the hindgut. Now there's also para-aortic nodes, and these are the nodes lateral to the aorta, and these are draining lymph from all the vessels that we just discussed supplying those organs. So the kidneys, the adrenal glands, the testicle, ovary, uterus, fallopian tubes, as well as the posterior abdominal wall and the iliac nodes, the para-aortic nodes, are draining and receiving lymph drainage from that region. Now, the cisterna chyli is the lower dilated end of the thoracic duct, and you heard about the thoracic duct up in the chest and in the thorax. And if you remember, thoracic duct drains everything below the diaphragm and then the upper left of the trunk. And this will be why this will make sense to you now that you know that. But the cisterna chyli, which is the lower dilated end of the thoracic duct, sits between the right cruce of the diaphragm at about the LV1, LV2 level, and that receives the lymph drainage from everything we talked about, the intestinal and the lumbar trunks. So all those pre-aortic nodes and all those para-aortic nodes and the iliac nodes on both sides are receiving the lymph, draining and emptying into the cisterna chyli. So that's why the lymphatic drainage below the diaphragm from both sides is in the thoracic duct. So here in this image you can see the thoracic duct, and you can understand now how everything below the diaphragm drains into that thoracic duct, and then the thoracic duct gets the left upper side of the thorax, and then the right lymphatic duct will get the right side. But that is anatomically why this occurs. So everything below the diaphragm is draining and emptying into that cisterna chyli from the para-aortic nodes, pre-aortic nodes, and inguinal nodes. Okay, moving on to the posterior abdominal wall, or posterior abdominal muscles now. There's quadratus lumborum, psoas major, psoas minor, and the iliacus. So the quadratus lumborum you can see extending from the iliac crest and transverse processes to the 12th rib. Helps to depress the 12th rib as well as flex the trunk laterally. The innervation here is the subcostal nerve, as well as L1, 2, and 3. And then you can also notice the psoas major, which we'll hear more about when we get into the pelvis. And this extends from the transverse processes and bodies of T12 to L4 to the lesser trochanter of the femur. It will fuse with the iliacus muscle to form the iliopsoas, and this is the major flexor of the hip and is innervated by L2, L3. The psoas minor muscle extends from the bodies of T12 to L1 to the pectineal line. It is not always present. In a small percentage of people it is absent, so if you don't see one, you may have a cadaver that is absent, but the majority will have a psoas minor. This aids in flexion of the trunk and is innervated by L1. And then there's the iliacus muscle, which extends from the iliac fossa and sacral ala to the lesser trochanter. This courses, as we heard earlier, with the psoas major to form the iliopsoas, and is the major flexor of the hip, and this is innervated by the femoral nerve. So the lumbar plexus, which you see here, is formed by the ventral rami of L1, 2, 3, and 4. The subcostal nerve, which is T12, is included here, although it's not technically part of the lumbar plexus. So we'll review the subcostal nerve, which is T12, and then the iliohypogastric, ilioinguinal, lateral femoral cutaneous, genitofemoral, femoral, and obturator nerve, which is all formed by the lumbar plexus. So first, the subcostal nerve, or T12, again, it's usually not part of the lumbar plexus, but it sits anterior to the quadratus lumborum, inferior to the 12th rib. You will be able to identify this coursing laterally over the quadratus lumborum and just below the 12th rib. The iliohypogastric nerve, which consists of L1 spinal segments. The ilioinguinal nerve also consists of L1 spinal segments, but the next nerve coursing out laterally from the psoas and coursing over the quadratus lumborum muscle is the iliohypogastric nerve. And this provides sensation of the skin above the pubic region and the hypogastric region by the anterior cutaneous branch. Also provides sensation of the gluteal region from the lateral cutaneous branch. The ilioinguinal nerve, which again consists of L1 spinal segments. Courses again laterally from the psoas and more inferiorly than the iliohypogastric, but also courses over the quadratus lumborum muscle. We will see later on how this continues on along its course with the spermatic cord or the round ligament of the uterus. It courses through the superficial inguinal ring. This will provide sensation of the upper medial thigh, also the root of the penis or the mons pubis, and anterior scrotum or superior portion of the labia majora. Sometimes keep in mind the ilioinguinal and the iliohypogastric, instead of emerging from the lateral border of the psoas as two distinct nerves, occasionally you can see where the iliohypogastric and ilioinguinal will emerge from the lateral border of the psoas muscle as one nerve and then branch into two. So keep that in mind. The genitofemoral nerve, which consists of L1 and L2 spinal segments, descends on the anterior surface of the psoas muscle. So this is real easy to identify. It pierces through the psoas muscle and then descends straight down inferiorly. It gives off a genital branch which enters the inguinal canal through the deep inguinal ring, which we will see later on, and courses with the spermatic cord and innervates the cremaster muscle, which you will learn more about in the pelvis. It also gives off a femoral branch, which courses beneath the inguinal ligament and supplies the skin overlying the femoral triangle. The lateral femoral cutaneous nerve, which consists of spinal segments L2 and L3, is another one that emerges from the lateral border of the psoas muscle, and it is just inferior to the ilioinguinal nerve, courses anterior to the iliacus muscle, and also courses posterior to the inguinal ligament. This will innervate the skin of the lateral thigh. Now the femoral nerve, which is the easiest one to find down here because it's so large, consists of spinal segments of L2, 3, and 4. This comes from you'll be able to see it coursing from the lateral border of the psoas muscle, and it will descend between the psoas muscle and the iliacus muscle. Courses on to enter the femoral triangle, where we'll see it later on, and courses deep to the inguinal ring. And we'll see this again later on. We'll be able to see where it originates from the lateral border of the psoas muscle and courses inferiorly, and then we'll pick this up again later when we get into the femoral region. This supplies motor to the anterior thigh or the quadriceps muscle. And again, we'll get more detail on that when we get into the extremity. It also provides some sensation to the anterior lower medial thigh, and it's important in the knee-jerk reflex that you'll learn about in your physical exam. This is the afferent, provides the afferent and the efferent limbs of that knee-jerk reflex. Now the obturator nerve, which consists of spinal segments L2, 3, and 4, also sits on the medial border or the medial aspect of the psoas muscle and courses inferiorly. So this one's fairly easy to find too, and not quite as big as the femoral nerve, but still fairly large and easy to find. Again, it descends on the medial border of the psoas. It exits through the obturator foramen and enters the thigh, and in the thigh you will learn that it innervates all the adductor muscles, or all the medial thigh muscles, as well as some skin of the medial thigh. And then here is just a picture showing you all of those nerves, the lumbar plexus, and all the nerves that we talked to. So coming off laterally, when you get in a lab today, when you find the psoas muscle, and you'll find 4 smaller nerves in the retroperitoneum coursing laterally over the quadratus lumborum and the iliacus muscle. And starting just below the 12th rib, there will be the subcostal nerve, and then the iliohypogastric nerve, and then just inferior to that, the ilioinguinal nerve, and then just inferior to that will be the lateral femoral cutaneous nerve of the thigh. You'll also identify the genitofemoral nerve piercing the psoas muscle and coursing anteriorly to the psoas muscle down inferiorly. And then on the lateral border of the psoas muscle, you identify the femoral nerve, and on the medial border, coursing inferiorly by the psoas muscle, you'll find the obturator nerve. Now, moving on to our final topic, which is the diaphragm. It's a parachute-shaped structure. It's not flat like we think, but it's actually a parachute-shaped structure. It's muscle, rises from the xiphoid process, the lower 6 costal cartilages, the vertebral L1, L3 vertebral bodies, and on the left it's the L1, L2 vertebral bodies, and on the right it's L1, L2, and the L3 vertebral bodies. There's a couple of ligaments, they're called arcuate ligaments of the diaphragm, which you need to know about and identify in lab. And these arcuate ligaments are just thickenings of the parietal peritoneum, and you'll be able to see these. There's a median arcuate ligament, which is in the middle, and that's what's coursing and arching over the aorta. So that's really easy to identify. There's one median arcuate ligament, then there are two medial arcuate ligaments and two lateral arcuate ligaments. So the median arcuate ligament arches over the aorta, and then just lateral to that on both sides is the medial arcuate ligaments, which is arching over the psoas muscle, and then lateral to that are the lateral arcuate ligaments, which are arching over the quadratus lumborum. So be able to identify those, and again, these are just thickenings of the parietal peritoneum, which you'll be able to see. Median arcuate ligament, medial arcuate ligament over the psoas, and then the lateral arcuate ligament over the quadratus lumborum. There's a couple hiatuses, or the regions between the two crura where structures are passing. So we've kind of gone over all these already, but there's the aortic hiatus, which is at the level of TV12. The aorta passes through, as well as the thoracic duct and the azygos vein. There's the esophageal hiatus at the level of TV10, where the esophagus passes through, as well as the vagal trunks, the anterior and posterior vagal trunks. And then there is the caval hiatus at the level of TV8, where the inferior vena cava and the right phrenic nerve pass through. So TV8, 10, 12, the hiatuses with the IVC, esophagus, and aorta. And then a couple clinical correlates with the diaphragm. Hiatal hernias, you've all heard of these, and this is just where there's protrusion of the stomach up superiorly through the diaphragm. There are a couple different types of hiatal hernias, which you'll learn about later on. There's sliding hiatal hernias, there's paraesophageal hiatal hernias, but the most common is a sliding hiatal hernia, and that's just where the junction between the esophagus and the stomach is known as the GE junction, or the gastroesophageal junction, and that should be at the level of the diaphragm, and then all of the stomach and its contents should be below the level of the diaphragm. Well, when that gets pulled up for whatever reason, and a portion of the stomach is up above the diaphragm, that's known as a hiatal hernia. And that gives to reflux symptoms, sometimes some chest pain because of the reflux, and can lead on to other sequelae, which you'll learn about from chronic reflux, such as Barrett's disease, and predisposes some people to cancer, have a higher risk of cancer if you do develop Barrett's disease, and these hiatal hernias, which sometimes can increase the reflux, can contribute to that. Okay, that will conclude our presentation on posterior abdominal viscera, kidneys, ureter, aorta, and a little bit on the diaphragm. So hopefully that was clear to you. Again, if it wasn't, do not hesitate to contact me or get in touch with me. I'll be happy to clear up any confusing areas or any confusing points. My email is denham@etsu.edu, denham@etsu.edu, if you have any questions.